Hello guys, and welcome to another crash course video. Today we're going to be looking at valvular abnormalities. So that's going to include what is stenosis and regurgitation, signs and symptoms, pathophysiology. We'll be looking at history and a clinical examination as well as some OSCE tips, and then we're going to finish with some questions. So what is stenosis and regurgitation? So if a valve doesn't open properly, it's known as stenosis. And if a valve doesn't close properly and allows the backflow of blood, it's known as regurgitation, or sometimes it's called insufficiency. It is possible to have mixed valvular disease, so you'd have a combination of stenosis and regurgitation. So signs and symptoms. Most valvular abnormalities are asymptomatic, so it's very rare to have symptoms early on in the disease. Only when they become moderate to severe do symptoms begin to manifest. A thrill is a palpable murmur, and a heave is a sign of ventricular hypertrophy. Heart failure is usually only seen in severe valvular disease, as hypertrophy has to develop beforehand. Dyspnea is usually associated with heart failure, but it can also be seen earlier valvular disease before heart failure on exertion. Angina, effort syncope, and stenosis can be seen as less blood is pumped around the body, which therefore can affect various parts of the body. And then we've got extra cardiac signs such as splint hemorrhages and osmosis, which are indicative of infective endocarditis, and a malaflush, which is usually seen in mitral stenosis. Okay, so pathophysiology of aortic stenosis. The aortic valve is open during systole and closed during diastole normally. So if it doesn't open all the way during systole, it's known as stenosis. Aortic stenosis is usually caused by fibrosis that can cause fusion of the cusp, known as commissural fusion. Fusion or fibrosis of the valve means that it can't open properly, and this can be caused by a number of reasons. Mechanical stress over time can cause fibrosis and calcification, which hardens the valve and makes it more difficult to open completely, and this type usually shows up in late adulthood in patients over 60. Patients can have a bicuspid aortic valve, which means they have two cusps instead of three, and are therefore more at risk of fibrosis and calcification, as the mechanical stress is spread out over two cusps instead of three cusps. Chronic rheumatic fever, which is the repeated inflammation and repair, which leads to fibrosis and even fusion of the cusp, which we've said is that commissural fusion. So the left ventricle has to produce high pressure in order to get the same amount of blood through the valve, and the left ventricle will thicken its muscle through left ventricular hypertrophy in order to produce this high pressure. This compensation is not always enough, meaning that less blood is pumped to the body, and the person is at increased risk of developing heart failure and various other symptoms such as effort syncope and angina on exertion. An aortic stenosis murmur is described as an ejection click followed by a crescendo-decrescendo murmur. Pressure from the left ventricle builds up until it eventually pushes open the valve, causing the characteristic click known as the ejection click. Then as blood is flowing through a narrowed opening, this causes turbulence known as a murmur, which initially gets louder and then quieter as the blood flow subsides. And this is what is described as the crescendo-decrescendo murmur. An aortic murmur sometimes can be heard more clearly with the patient sat forward and with their breath held out as well. So now we're moving on to aortic regurgitation, and that's where the aortic valve doesn't close all the way in diastole and blood can flow back into the left ventricle. About 50% of cases are caused by aortic root dilation, where the root dilations pulls apart the cusp so that the valve can't close all the way. Aortic root dilation is usually idiopathic, but it can be caused by aortic dissection, aneurysms, or syphilis. Valvular damage is caused by infective endocarditis or chronic rheumatic fever, which causes fibrosis, but instead of fusing the cusps together, it means that the valve can't form a nice seal. As there's backflow into the left ventricle, this means that there's an increase in blood volume and therefore an increase in stroke volume, as there's more blood to be pumped out during systole. This causes an increase in systolic blood pressure. However, during diastole, there's less blood in the aorta, meaning diastolic pressure decreases. A high systolic pressure and a lower diastolic pressure means that there's an increase in pulse pressure, which is just minusing diastolic pressure from systolic pressure. This is referred to as hyperdynamic circulation and produces a bounding or water hammer pulse as blood slams against the walls of the artery with each heartbeat. This can also produce Quincke's sign, which is the pulsating of the capillary beds in the fingernails. So over time, the increase in blood volume in the left ventricle causes left ventricular hypertrophy, and patients with aortic regurgitation will have an early decrescendo diastolic murmur caused by blood flowing back through the valve. And aortic murmurs, as we said, are best heard with the patient sat forward and with their breath held out. Mitral stenosis. So during systole, the valve closes, and during diastole, the valve opens. and if the valve does not open all the way during diastole, it's known as mitral stenosis, as the left ventricle is not filled with as much blood. So it's most often caused by chronic rheumatic fever. The volume of blood in the left atrium increases, leading to higher pressures. Higher pressures flowing through a fibrotic valve makes a snap sound when it opens, which is followed by a diastolic rumble as blood is forced through a smaller opening. A constant elevation in both blood volume and pressure in the left atrium causes it to dilate, allowing blood to back up into the pulmonary circulation, causing pulmonary congestion and pulmonary edema, which can lead to dyspnea. All of this extra blood can cause pulmonary hypertension, ultimately making it harder for the right ventricle to pump blood to the lungs. And over time, the right ventricle can hypertrophy, which can lead to right-sided heart failure. In addition, the extra blood volume causes the left atrium to dilate and the muscle wall to stretch, irritating pacemaker cells and increasing the risk of arrhythmias such as atrial fibrillation. Left atrium dilation can also cause esophageal compression, which can lead to dysphagia. And a mitral stenosis murmur is also known as a diastolic crescendo murmur, occurring after an opening snap. So regurgitation. So this is when the mitral valve doesn't close all the way in systole, and blood leaks back into the left atrium. The leading cause of mitral valve regurgitation, and the most common of all the valvular conditions, is mitral valve prolapse. When the left ventricle contracts during systole, a very high pressure is generated in order to pump blood out of the aortic valve, but that also means there's a lot of pressure pushing against this closed mitral valve. Normally the papillary muscles and chordae tendineae will keep the valve from prolapsing, but in mitral valve prolapse, the connective tissues of the cusps and the surrounding tissue are weakened. This results in a large valve area and elongation of the chordae tendineae, which can sometimes rupture, which typically happens to the ones in the posterior cup, allowing it to fold up into the left atrium. Patients with mitral valve prolapse are usually asymptomatic, but they often have a classic heart murmur, which includes a mid-systolic click, sometimes followed by a systolic murmur. The mid-systolic click is caused by the posterior cusp folding into the left atrium and then suddenly being stopped by the chordae tendineae. Mitral valve prolapse doesn't always cause mitral regurgitation, but it often does. We've also got damage to the papillary muscles due to myocardial infarction, which can cause mitral regurgitation, meaning that the chordae tendineae, meaning that the papillary muscles cannot support the chordae tendineae and the cusps can flop open. Left-sided heart failure that leads to left ventricular dilation can lead to mitral regurgitation as well, because as the left ventricle dilates, it stretches the mitral valve annulus and lets blood leak into the left atrium. So as we've already mentioned, chronic rheumatic fever is another cause as well, which is because it's causing fibrosis of the cusps. Left-sided heart failure can cause mitral regurgitation, but this can also work the other way. Blood leaks back into the left atrium and then drains back into the left ventricle. This means that there is a volume overload in both the left atrium and the left ventricle, and this leads to left-sided hypertrophy of the heart, which can lead to left-sided heart failure. So patients with mitral valve regurgitation typically have this pansystolic or hollow systolic murmur, meaning that the murmur can last for the duration of systole. Mitral valve murmurs are best heard with the patient lying on their left side with their breath held out. So tricuspid stenosis. So that's when the tricuspid valve doesn't open all the way during diastole, meaning it's difficult to fill the right ventricle with blood. So it's usually caused by chronic rheumatic fever, and that usually affects the mitral and aortic valve as well as the tricuspid valve. The opening narrows, making it harder for blood to flow through from the right atrium to the right ventricle. And when the blood finally pushes open the fibrotic valve, it makes a distinctive snapping sound, which is followed by a diastolic rumble as the blood is forced through a smaller opening. As it's harder for blood to get through, blood volume and pressure increases in the right atrium, causing it to dilate, resulting in blood getting backed up into the veins. In addition, when the right atrium dilates, the muscle wall stretches and irritates pacemaker cells, therefore increasing the risk of arrhythmias such as atrial flutter or atrial fibrillation. Okay, so tricuspid regurgitation. The tricuspid valve won't close completely during systole, and we get blood leak back into the right atrium. It's usually due to pulmonary hypertension, which causes an increase in right ventricular pressure, which then dilates the tricuspid valve, allowing blood to go backwards. And again, chronic rheumatic fever can cause tricuspid regurgitation. We've also got damage to papillary muscles through myocardial infarction, meaning that they cannot anchor the chordae tendineae, allowing the tricuspid valve to flop back, which allows blood to leak back into the right atrium. We've also got congenital causes, such as Epstein anomaly, which is when the cusps are located too low and within the valve. So the extra blood that leaks back into the atrium ends up back in the ventricle during diastole. This means that there's an increase in right ventricular preload, and in order to deal with this, there is right ventricular hypertrophy. This stretches the annulus of the valve, therefore worsening the regurgitation. So this compensation can work for a while, but eventually the right ventricle might not be able to keep up, and it can lead to right-sided heart failure. And the movement of blood back into the right atrium can be heard as a pansystolic or hollow systemic murmur. So pulmonary stenosis is when the valve doesn't open all the way during systole. It's often congenital cause, which means from birth the cusp may not be fully developed or irregularly shaped. And pulmonary stenosis is often associated with congenital heart diseases such as tetralogy of Fallot or Noonan syndrome. We've also got mechanical stress as a cause, which causes damage to the endothelial cells around the valve, causing fibrosis and calcification, which hardens the valves and makes it more difficult to open all the way. So the right ventricle has to create very high pressures, meaning the right ventricular hypertrophy occurs. The heart still might have problems getting blood through the valve and into the lungs, meaning blood is backed up and the heart and the patient is at a risk of developing right-sided heart failure. And a pulmonary stenosis murmur sounds very similar to an aortic stenosis murmur, so it's this crescendo-decrescendo murmur. So pulmonary regurgitation is when the valve doesn't open all the way during systole, allowing a backflow of blood into the right ventricle. It's usually because of valvular damage, such as infective endocarditis or chronic rheumatic fever. And the backflow of blood increases the right ventricular blood volume, meaning that over time, right ventricular hypertrophy occurs, and the right ventricle may not always be able to keep up, and this can lead to the right-sided heart failure. And the murmur is a diastolic decrescendo murmur as blood is leaking back into the ventricle. Okay, so we've got a history here. A 75-year-old male presents to his GP with chest pain, shortness of breath, and some instances of lightheadedness and fainting that he notices when he's walking to his local supermarket. He admits that this has been happening for a while, but he's been able to cope so far. So what would you want to do next? You might want to pause the video and have a think there. So obviously we want to do a CVS examination. So on examination, an ejection click followed by a crescendo-decrescendo murmur is able to be heard in the second intercostal space on the right sternal edge, and the murmur can also be heard slightly louder with the patient sat forward. So what would be your differential diagnosis? Again, you can pause the video. So diagnosis would be aortic stenosis. Why? Risk factors for a start, symptoms and signs. So firstly, the patient's male and over 60. His symptoms are those with aortic stenosis, angina, dyspnea, syncope. And finally, the patient's murmur is that classic description of an aortic stenosis murmur. So some OSCE tips. Remember to check for signs in the nails. Remember to check for those collapsing wartime pulses. Remember to inspect the face. Remember to check for heaves and thrills. And make sure you learn how to describe a murmur. So you can pause the video here and this shows you how you would describe a murmur. And finally, learn the basic murmur grading scale, which is called the Levine scale. And again, you can pause and have a read of the Levine scale there. Okay, so some questions. So question 1, what is stenosis? Is it the valve cusps have gone through commissural fusion, the valve doesn't close properly, the valve hangs down, or the valve has become fibrotic? So try to think about what is happening to the blood during stenosis and what might cause this. Again, pause the video and have a think. So the answer would be A, the valve cusps have gone through commissural fusion. So question 2, what can left atrial dilation and mitral stenosis cause? Collapsing pulse, syncope, dysphagia or raised JVP. And for this, consider the surrounding structures of the heart. The answer would be dysphagia. And question 3, what is used to grade a murmur? Wells criteria, TNN staging, GCS or Levine scale. And try to think about what the other answers might relate to. So the answer would be the Levine scale. Okay, thank you very much for listening, guys. If you've got any feedback, please let us know. And thank you very much for watching.